Welcome to the panel. I'm Terry Seguin. You may recall in the first panel that we did, it was a wide-ranging subject. We were talking about the state of New Brunswick. Well, it didn't take long for that conversation to become focused on the state of healthcare in the province. That was an issue that our panelists thought deserved most of the attention. And after talking about healthcare for an hour, it occurred to me that there was a larger conversation to be had about the state of healthcare in New Brunswick. And so, for this edition of the panel, I am joined in the studio by New Brunswick's Health Minister, Bruce Fitch. Robert Gauvin is here for the Liberals, and Megan Mitton is here for the Greens. Welcome to you all.
Thank you.
Thanks for coming.
Okay.
During the time that I have been in journalism in New Brunswick, I have recognized that the healthcare system has been the focus of much discussion. The system was always seen as trying to cope, sometimes succeeding, sometimes not. But I don't think I've ever seen the healthcare in New Brunswick reach the stage it's at now. And some people, well qualified, have described it as a system in crisis. And what I'd like to know from you, Mr. Fitch, what happened to push our healthcare system from that state of underlying concern to a state of crisis? What's your understanding of why that happened?
Well, that's a good question, Terry, and it's great to be joined by my colleagues in the legislature to have this discussion. Sometimes in question period, you go back and forth and only have a limited amount of time to maybe expand on some of those ideas and reasoning behind certain decisions and whatnot. But there's a lot going on in healthcare, and there's many people day in and day out stepping up and leaning in and doing a great job. Every time I'm near a microphone, I want to say thank you to not just the frontline worker, but all the support around those frontline workers as well. But there's, I guess, as the last 2 years of the pandemic occurred, there was a significant amount of stress put on the individuals working in the healthcare system. And I think you're seeing some that have chosen to retire, move out or change their vocation, and that has put a shortage of staff almost right across the system. It's not unique to New Brunswick. It's not unique to Canada.
Sure.
It's all over the globe, which is interesting that we can talk about some of the recruitment efforts in trying to alleviate that. But I think when it comes down to that HR issue, that seems to be one of the underlying issues, whether you're wherever you are in the continuum, whether it's having enough staff to have the beds open in the nursing homes so that people can come out of the hospital, get the care in either the special care home or the nursing home or back to their own homes, which will allow the flow of patients to go in, either get their surgeries, whether they're hip, knee, whatever, cancer, heart, and again, finding the primary care out in the community at the right spot, in the right place. And again, there's been some interesting technologies that have come forward since the pandemic that are allowing people to make contact with the physicians to address some of those issues, plus some of the things that have been done in the pharmacy. But again, that has where there's been the focus of if people don't get that primary care out in the community, then they're coming to the emergency room, and that's where we're seeing that jam, whether it's in the ambulance or walk-in. And it's the system has to flow where if you are not getting that assessment or treatment out in the primary care, then you're moving into the hospital. And that's some of the discussion we had about emergency rooms having to be triaged, people having to be triaged, and maybe not getting the attention as soon as they would like or should.
You were brought in to replace Dorothy Shepherd. So what have you done since you became health minister to make things better?
Well, I think we only have an hour for the show, right? And there has been a significant amount of work done. And not to just personalize it me, but even within the department as well. But I know the first thing I did was listen to the frontline workers. I mean, there's thousands out there, so obviously you don't get to talk to each and every one of them.
Right.
But and again, meeting with some of the physicians, meeting with some RNs, NPs, some students, and again, patients that have some have had good experiences, and there is a balance there. A lot of times, media would like to focus on a one-off or a bad situation or
Like
a bad
someone
outcome.
dying in an emergency room.
And that's tragic. I don't think there's anybody would disagree that that's a tragic situation.
So you can understand why the media would focus on that.
Sure, and again, they're bringing light to situations that need to be addressed or changed, especially if the system failed due to whatever reason, and that's part of our job, is to say, okay, why did that particular situation happen, and should things be changed?
Well, what's going on with that? There was back in July, the minister said, okay, tell us what happened. So here we are 2 months later. Do we know what happened? How did that person end up dying in the emergency room?
Well, and that's one of the difficulties as being the minister and confidentiality of patients that go in and go out of the care of the hospital or in long-term care. So again, it's you're almost having a discussion with not being able to give a lot of details as to what happened.
Have you received a finding? I mean, has an investigation been completed?
Well, and one of whenever anything like that happens, there's an analysis of what happens, and the RHAs again are the ones that have been tasked with again needing to address some of the gaps in either care or the gaps in the process that could lead to this. And I would probably suggest, I don't know if at some point in time maybe you'd want to have the trustees or the CEOs in from the RHAs to have that discussion. I'm not volunteering.
If you could
them,
arrange that, I would take you up on that in a minute.
This is your show, not mine.
Well, no, but I mean, if you have pull, you have way more pull than I do.
But when you get down into some of those day-to-day operations,
right,
they have a significant amount of information beyond my level of fully understanding. But I know, again, when one of the things that occurred after that incident, there were changes within the for instance, people checking on the people in the waiting room.
Okay.
Extra staff was put on in order to, again, check vitals, check the condition of people. So there have been a number of changes that have occurred within the system of the waiting room in order to, again, check on patients on a more regular basis.
And you're satisfied that the changes that you know of will prevent this from happening again?
Again, you cannot predict what the outcome is of a person who presents themselves at the emergency room. And again, if it's an emergency, again, people could be having heart attacks, they could be having some type of an aneurysm.
Sure.
I mean, there could be other deaths occurring, but again, trying to get people triaged as soon as possible to move them into the care where they need to be addressed, or their system needs to be addressed. And that triage occurs, again, at a level that's clinical, beyond my training or our training.
Sure.
But again, that's some of the response is making sure that the patients are being monitored as they're waiting in the emergency room.
Mr. Gauvin, how did the system reach the crisis stage?
Well, that's a great question, because we have to understand it so we can move forward. First of all, it's good to see you again, and nice to be here with the colleagues from the Ledge. How do we get here? Bruce touched on it a little bit. I think we didn't listen enough in the last 2 decades.
Listen to who?
To the people on the ground, people who are actually working in the system. And the last 2.5 years, that's what I tried to do. I tried to meet people as much as I could. And one thing that they told me that stuck with me, because that was the most common answer that I got, was they would love to work more in teams. That would provide better protection for the patients. Like not enough people have access in the healthcare system. Not enough people, let's take you for example, have access to your file. So if you go into an after-hour clinic, they don't have access to your file. Say, well, take those pills and good luck. So if you had teams now, teams would be, you have RNs, nurses, doctors, mental health specialists. You would have better protection, more people taking care of you, longer protection during the day. That was one thing. The other thing that does is that every day now, pretty much every day, I don't know the last few months, they had 20 to 25% of nurses not showing up to work. That tells me that they're not happy. They would take Fridays and Mondays, and some would leave a burnout and depression. Working alone did that for them. So if they would be part of teams, you feel accountable to the rest of your team, so you show up to work.
But to be on a team, you need teammates, and isn't that part of the problem? The difficulty in finding teammates?
Exactly. Well, that's the chicken and the egg. But right now, as you touched, one of the worst problems right now in healthcare is people leaving. People who are still having a lot of years left being able to work. We have problems with retention, and I get it. It's not an easy fix, and it should not be a political thing. But people are leaving right now to do something else, and parts of that is that they're not happy with what they're doing because they didn't choose a job. They chose a vocation. Being a nurse is being a vocation, and right now, something has to be fixed because we cannot afford to lose, like the last 2 years, 225 nurses left for reasons other than retirement. So
what are the other reasons? They're not getting paid enough?
Well, I don't. This would have to relationship with governments, work conditions, because they work 4-day shifts of 12 hours. But the problem now with the staff shortages, they have to come back to work. They're 3 days off. They have to come back to work because of staffing shortages. And because they love what they do, and it's a vocation, like I said, they go to work. You can only do that for a certain amount of time before you burn the candles at both ends. So I think that's what's happening.
Ms. Mitton, how did we get to the crisis stage we're at?
Well, Terry, good to see you. And everyone saw this coming, and no one did anything about it, frankly. I remember when I first ran for office in 2014, the Nurses Association came and met with me in my campaign office. And they were saying, listen, there's going to be this many people retiring. There's going to be a nursing shortage. There's going to be a crisis in healthcare. If I knew that, that means all the folks in government, all the people who this is their job to look at it, all the politicians must have known that. And it's really frustrating because everyone's really dragged their heels on addressing these issues of burnout, of workplace safety, of increased injuries, other things. And it has been this feedback loop where people are burning out, they're getting injured, they're leaving the bedside because their working conditions are so difficult. And it is a calling. These people who work in healthcare want to save lives. They care. And at the same time, they have been burning out. And there has not been enough of a focus on retention, on recruitment, on making the workplace safe, and on restructuring and refocusing what our healthcare system is doing. We obviously need hospitals, we need ERs, we need emergency care, and we need primary care, and we somehow never get to preventative care, but that's arguably one of the most important things because we cannot sustain what's happening in terms of chronic disease management, in terms of what's happening in terms of our population health. And yet, when you look at the reports that come out from the nurses, when you look at the reports that come out from the doctors and other experts, that's one of the first things they talk about. Doctors talk about developing an approach to reduce poverty. The nurses are talking about, union talking about making sure that we actually look at preventative health care. If we don't do that, we're dropping the ball and we're guaranteeing that things will be worse in the long term. And that's what got us here. If we don't actually focus on preventative health care, on primary health care, then I don't think we have a chance to fix anything else.
Whose responsibility is it to ensure that we have adequate recruitment, that all of these problems you just outlined are being taken care of? I mean, is it government? Is it administrators in the system? Who has that responsibility?
Well, ultimately, it's a shared responsibility. Like the Ministry of Health is responsible and works with the regional health authorities. And we have seen some concerning issues in terms of governance, in terms of getting rid of the partially elected boards, in terms of firing the newly appointed CEO, Dr. Dornan, and just trying to find someone to throw under the bus because of what happened. When there had been warnings from doctors, for example, ER doctors had written a letter and said, this is going to happen. And now it's happened where people, someone died in the ER. And that's not the only one. There have been many stories. And I know that the nurses and the doctors have been ringing the alarm bell and have been working so hard to do their jobs under difficult conditions. And I appreciate and thank them for their work. And they've been working under impossible conditions where they say themselves patient care isn't always where it needs to be because it's just an impossible situation.
Minister Fitch, do you want to respond to that? Or
Well, let's look at some of the steps that have occurred. I know I started down that path of what have we done in the last little bit to improve the situation. And not to throw names for your show, because it's not my show, it's your show. I've worked very, very closely with Trevor Holder in changing some of the medical seats for the doctors to, again, boost up the numbers here in New Brunswick, because you have a better chance of retaining a doctor if that seat is in New Brunswick. So there was an announcement in St. John just recently about 10 seats being repatriated, and there'll be some more announcements on that in the near future. Plus,
in terms of increasing numbers?
Right.
How many more seats?
Well, you got to wait till the announcement.
Why?
Well, because I got some other things I want to talk about too, and I don't want to
Okay,
take
just answer
Trevor's-
that question,
No,
though,
I don't
about
want
the
to take
numbers.
Trevor's
Okay, so he's going to
announcement.
announce it? But you're the health minister.
But it's under post-secondary education training.
Okay,
and labor.
okay.
Yeah.
When's that going to happen?
I don't have the exact date, but it's,
Before Christmas?
Boy, he's for a guy retired, he sure doesn't. Yeah, no, we hope to have some announcements very soon. But
Okay.
the other one thing I want to share with you was about nursing seats at UM and UNB. That's been increased by 85. So now there's a total of about 366 that will be graduating in those programs, and there's going to be some more announcements on that one too.
Once they
So stay
graduate,
tuned.
how do you ensure that they stay here and they're not going to the States or Ontario or Alberta? How do you do that?
Well, again, there's some different programs that we use as incentives to stay, and I'm also thinking of some.
Are they effective?
Again, people make decisions. We'll hire every one of them that comes out of the thing. Well,
Why?
I guess we hear stories that that's not what actually happens. That there are people who want to work here and they don't always get offered the job.
Well, anyways, Terry, going back to where we, again, from an RHA standpoint, there's short nurses there. There's short nurses in the special care and the nursing homes. So again, there's capacity to take those nurses that are graduating, and people make choices if they want to be full-time or part-time. When you're part-time, you can manage your hours a little bit better, as opposed to full-time where you've got a schedule and you have to adhere to that schedule. Again, getting down into some of the nitty-gritty that again are negotiated with the union contracts. The other great news story is EMTs and ambulance bringing back. Class is going to start, a class of about 20, I think it is, by the end of this month in Moncton, and those EMTs will free up some of the other paramedics and advanced paramedics to do other jobs or get back on the road to provide some service. So that's really an initiative that is pretty exciting.
Will there be a corresponding increase in ambulances?
Well, again, with more HR, and again, they're looking for staff in that aspect too, be it paramedics. The more staff you have on the road, the more ambulances that will be available. And there's that strategic deployment throughout the province.
Okay, Robert Gauvin.
Yeah, and it's also, and it's not easy, of course not easy, but since last, we're talking about people leaving, and we have to ask questions, that's our job. Since the last summer, 4 or 5 oncologists. I don't wish you to need an oncologist, but if you need one, you should have one. And we lost 4 or 5. You probably got phone calls from women with breast cancer. They have to wait months. And when you have cancer, time might be of the essence. So we've lost 4 or 5. They did not change provinces to go work in aviation. They stayed in that field of medicine, healthcare. So how do we address that? Because this happened. So we have to ask the question: why did they leave?
Well, it's working conditions or it's remuneration, isn't it?
Or
That's-
both.
Or
yeah,
both.
Or both.
Is it? What's
So
your
I
understanding?
think it's fair to have those questions answered, because this is frightening, because each oncologist, thousands of patients that have to wait longer because we have fewer of them. So I think that's a fair question.
Minister, why are they leaving?
Well, and there's exit interviews done, and people have various reasons, but we also have people being hired. When you look at the net at the end of the year, we've been coming ahead every year on on doctors. But this goes
Sorry,
back
I didn't follow
well,
that.
so many retire or
Right.
leave, but there's also a number being hired all
Okay,
the time.
and the net effect is a gain?
Yes, if you look over the years, it varies year to year, and depending on when in the year you look, we might be behind. But when a graduation occurs, again, and I made the commitment, I met with the first and second year medical students at Sherbrooke or UM, and actually I'm meeting the St. John first and second year medical students, and I basically told them right up, I may not be the health minister in 4 years, but I'll guarantee you'll have a job if you want to work in New Brunswick.
Okay, so in the oncologists that Mr. Gauvin is talking about, when you go through that equation, are we ahead on oncologists now or behind where we were?
I don't have that level of detail for you here today. We can
Okay.
always look back and see.
Mr. Fitch, is it possible that over several decades, several different governments, regardless of what color there are, we constructed a healthcare system in New Brunswick that was so vast, so spread over the province that it's impractical now, that we need to retrench and pull it back to some central locations, and maybe that will help?
Well, you're seeing different services in different locations, and I was up to the Bathurst Hospital, and there's a big expansion there, which again is going to modernize that hospital, and they have about 1,600 people working there. So it's not only important to the people of the area to get that service, but it's also important to as an economic generator. We were up because we had announced the cataract surgery clinic. Dr. Giovanni, who had invested his own money in putting a clinic in the area outside the hospital to take the pressure off the hospital. And that whole discussion on how that's going to affect the additional time in the surgery rooms in the hospital,
Right.
where they'll be able to do hips and knees and some of the cancer patient operations that are needed, because it used to take 2 days a week to do all the cataract surgeries, which is the highest wait list in the province. That wait list, which was about a year and a half, will now be brought down to 3 to 6 months. And again, plus the ability for the surgeons to operate on the other procedures that, again, have a long wait list and a long time on the wait list.
You know Dr. Yogi Segal, and he compiled a 10-page report and sent it to you and the Premier, and he said, okay, look, if you want to fix the healthcare system, I have some insight into what you should do, and some of the things he suggested, how emergency departments could be better staffed and operated, better compensation and more protection for nurses, boosting incentives to recruit physicians, nurse practitioners, and physician assistants for improved access to primary care. But one of the biggest problems, he said, is the lag in having eligible hospital patients transferred to nursing homes. So he's saying, you move people into nursing homes, you'll free up medical staff, you'll free up space in the hospitals. So how has the government done, how have you done in responding to those concerns that he raised?
And I do appreciate the information and the suggestion, and he and I did have a meeting, a Zoom meeting. He was gracious enough to take time out of his busy day in order to have that discussion. But we are working very closely with the discharge planners and the people that do the assessment for seniors that are in the hospital and taking up those beds, in trying to, again, move them out into community. And it's not just nursing homes, it could be a special care home,
Right.
It could be back to home with supports. Because sometimes people think, oh, they have to go to a nursing home. Well, again, with COVID, there was a plan to move folks out, and it was occurring quite nicely. But then COVID hit a number of the homes, which slowed that process down. But we've revamped it up and made some changes in how people make that decision. Instead, you used to have choice 1, 2, 3. Now, patients have 2 choices and equally weighted. Plus, you have an option to take an interim bed. So if you want to go to the Jordan, but there's no bed there, you could go to Spencer, stay there until the bed in Jordan came up. so you can take the interim measure.
Okay, go ahead, Mr.
But right now, as we speak, we have 461 people, seniors in hospitals, waiting for places in long-term care facility. And when nurses are taking care of these guys, they're not taking care of the patients. These people would be better served in a long-term care facility. The problem is, it's the same problem. It's staffing, and people are leaving. And I've been speaking to people who work in those establishments, because I'm the seniors critic, and some of them said there's supposed to be 5 people working by quarter of war on a shift. It happened 2, instead of 5, 3, 2, and some instances 1. And people get there, and I know a nurse just quit because she said, I had a senior had dementia, he attacked me, so I'm crying before every shift. Stuff like this happen. We're not making it up. So how do we, the main questions, and all of us alluded to it, how do we keep them in the system? This is the most important. This should be priority number 1. How do we keep the workers that we have who know the job, who cannot be replaced in 2 weeks? How do we keep them in the system? So that has to be addressed quickly.
Go ahead.
Yeah, I mean, I couldn't believe retention and recruitment wasn't one of the pillars of the health plan that came out last year. And we can talk about the health plan if we want, but one of the key things really is retention. Recruitment and training so that we can recruit people, those are essential. But if we're pouring water into a bucket with holes in it, then we're not really accomplishing much. And that's basically what's happening. And it's on all levels. We're seeing so much pressure, overwork, understaffing, and this isn't new. The pandemic made it worse. It's not new. My dad, when he was sick and in the hospital in 2014, I remember, and I'm not complaining, but like I was making his bed. The nurses didn't have time. They showed me how to do it. There wasn't a bed for him. He ended up in the hallway. Like I saw every single step of the way where the staff were doing their best and the system was just crumbling. And this is long before the pandemic. I could see what was happening and we've been warned by the workers there. And it's everything from the radiologists and people in every specialty. But then we talk about people wanting to be able to age in place in their homes, personal support workers and home care workers. My gosh, I met a really great one and she was amazing. And I saw her about a year later and she was working in a convenience store. The pay wasn't good enough. It was very precarious work. They often have to travel. It wasn't, she wasn't being compensated in a fair way. She couldn't make ends meet. And she was a really great home care worker. And so what does that tell us? We undervalue this really important work at every turn.
But is that government's fault that she left, or is that the administration's fault that she left?
I think government has a role to play in terms of what wages are. So we could talk about what the wages are. We know that most people aren't earning a living wage, and so that is a huge issue. And we could talk about the system where home care workers are through these private companies that manage it through extramural. I think there's a big administrative issue, and a lot of it gets privatized. And when we talk about privatization, people think, oh, I'm going to have to pay. And to be fair, that does happen. Mental health care, so many people have to pay out of pocket, and it's unacceptable. But there's another type of privatization where there's companies that are sort of middlemen, and that happens in a lot of different areas, and home care work is one of those areas.
Okay, let me just get to the minister on the question of, in some cases, we are not paying our workers enough to keep them in place. What are your options in that regard?
Well, and again, depending on which workers we're talking about, some are union negotiated, and again, some are based on the company that they work for, but we usually set the wage and make a significant investment. When I was social development minister, we had one of the biggest percentage increase in the investment in that sector, which was huge. About I think the overall budget was about 1.3. Health is about 3.2 billion, and there was about a 6% increase in that last year. next budget is coming up as well. But we put a significant amount of money at the end of last year to up the per diem in the special care homes, and again some of the salary increases to bump up some of the the home care workers as well. Again, to try and meet that demand. Look at there's a lot of people working very, very hard in that sector, and certainly the appreciation is there.
Do you
And
think if
there's-
you paid them more, Mr. Fitch, they would stay? That would help with retention?
Well, people make decisions on their own. Some of them are monetary, some of them are family related, some of them are, I know the special care home that my mother was in, it was almost like a multicultural. There was people from Brazil there, India.
Working, you mean?
Yes,
Okay.
yeah. So that international trained medical profession is some of the things that the government's been working on to try and alleviate the pressure for again, giving the care in the home or in the special care home or the nursing home. Vitality just came back from an announcement, or they made an announcement that they were out recruiting in Senegal. There was a list there, France.
Sure.
A number of the places, again, recruiting some help for the people that, again, need it, either receiving the care or the employees to help support them.
But when your government looks at the retention issue and says, how are we going to keep these people in these jobs, is it widely accepted in cabinet that paying them more would be beneficial?
And sure, everybody has had, again, that's always a discussion, how much more and how does that relate to the whole continuum? And I know there's a number of people that would, go work as an EA in the school system because of there was more money there. And there's some federal support going on with some of that work, and plus the daycare work as well, some federal money to boost those salaries. So, and that's part of the discussion again as First Ministers, the whole transfer, the health transfer question, and how that money, what it should be and where it should be spent. And there's been discussions going on that moves very slowly. But
Like our
again,
surplus in the province right now is, we could afford, you could afford, the government could afford to pay more, couldn't they?
well, and there's a lot of areas that need attention. And again, as time goes on, there may be some announcements that will be well received within the communities.
Well, this is your opportunity to make the
well,
announcement.
Yeah, exactly.
You can be a hero.
Look, I want to again respect the ministers responsible for their various portfolios.
There's one.
We'll just park that there. For
Okay.
Sorry to cut you off, but there's one thing we've met with Susan and some of the team. We've met the student council at University of Moncton, and their number one concern was internship for a student in the nursing program. The problem is they're not paid to do that. We could pay them to learn on the job if they go work, do their internship in a long-term care facility. The problems that occurs because of staffing shortages. After 6 months, they say, I'm not going to do this for the rest of my life. I'm not going to do work. I have to come to work on my days off and whatnot, and
Right.
24-hour shifts,
Right.
and it happens. But the internship are not paid. So they have, for 4 months, they have to go do their internship while they study in Moncton. They go maybe in Caracat or Edmundston. They have to keep their apartment in Moncton. I don't have to tell you how much more they have to pay than 5 years ago.
Mm-hmm.
Plus, they have to find an apartment in another all new locality and then work for peanuts. The number one ask from the student council was to have monetary help there. That would show interest in keeping our nurses. A letter and a guaranteed job is good, but saying, if you go right now, work, we're going to help you with your apartment, we're going to pay you to learn on the job, and that would show interest. It would show that you really care about keeping them and you're serious about keeping them.
And Ms. Mitton, you wanted to say something? You wanted to jump in on that?
Yeah, I mean, train, recruit, and retain. That's really what needs to happen. And the training part, it is very expensive for students to do their training. There needs to be more invested in actually paying for the tuition, in reducing the fees, let alone the clinical, les stages, the internships, thinking in French here, and making sure that they don't have these extra obstacles. There needs to be enough clinical placements. There needs to be all of that to flow through and support people. It's very expensive to do post-secondary education. I sometimes I think people who went to university a while ago might not realize the price now to go through. It's really changed, and it's not attainable for everyone. So even just the cost of it is a barrier for people who could otherwise enter the field and become healthcare workers. We really need to look at what that means to invest in these workers from the get-go.
So government should be doing what in that case?
Paying for tuition, reducing the fees, helping to pay for other things.
Does that work?
Again, there's various components or various programs, and the important part of a program where you give a grant or wherever is to have some type of a retention clause built in there. And unfortunately what's happening in some cases is other companies or provinces are buying out the contract and again taking some of that labor. Now I'm just speaking in generally, but sometimes with the physicians you'll see an agreement such as that. I think the reserves or the Army has a program similar to that, and that's sometimes what happens. So we have a bonus of $100,000 on the table for doctors that want to come here and work in the rural part of the province. So there are a number of different initiatives. We have I signed a number of letters of reimbursement of tuition to NPs and RNs the other day.
How many people have taken you up on that $100,000 bonus offer?
I'd have to look for that detailed amount. I didn't memorize that before I come to the show, but we can get you that number.
Okay, Robert.
And on the tuition, just to continue on that, I think every government has a responsibility. This is one of the most dire needs in New Brunswick is healthcare. So we should focus and make it as easy as possible, money-wise, for students to be able to help them, encourage them to go in that field, that they can work. Government will take care of a part of the tuition, and not a lot of families can afford university, as Megan was alluded to. So I think absolutely it's a responsibility of the government. All these things that we're talking about, those things show that we care. You said yourself, work conditions, this is part of it. And the money part of it, nobody wants to run under, especially with such a hard job. So absolutely, I think it's a responsibility of the government. Other jurisdictions around the world, they focus on the need of their country or their province or their state, and they help. Right now, the help needed is man and woman power in healthcare. So that should start there.
Okay. Mr. Fitch, one of the things I was hoping we could discuss today was what's going to happen when the baby boomer generation is getting to the point in their lives where they are going to require long-term care, medically assisted facilities. Mr. Gauvin just said we have 461 people in hospital now. Do we have 461 long-term beds for those people now? I mean, what is happening to ensure that when citizens of this province require that care, it is going to be there for them?
Yeah, exactly. That's a great question, and we continue to work on that. It's interesting that, again, coming down to that HR and some of the recruitment that is occurring. We had an event at the Fredericton Multicultural Centre talking about adding navigators to the system, and there was a
What
lady
is that? What does that
navigator
mean?
So if a foreign trained, internationally trained medical student comes to New Brunswick, or a nurse or a doctor, the navigator can help them come through the maze of how to get their credentials recognized by the either College of Physicians or the Nurses Association, and then get out into the, hired by the RHAs. And it was interesting because the young lady that spoke was from Brazil and had trained in the U.S. and actually Googled what province is the easiest province to navigate, and New Brunswick came up. Like, that was her story. And she had been here 3 months, and she expected another 2 months to be on the floor of the hospital. So that's a 5-month international student coming in. Now, that's just one. And David Campbell in Moncton writes many times about that international component and trying to expedite
Right.
the process of getting some of those internationally trained individuals here in New Brunswick.
So what's the long-term plan, though? I mean, right now, according to Mr. Gauvin, there are 461
Right.
patients in hospital who shouldn't be in hospital. And getting back to Dr. Seguin,
Yes.
these are the people that he says we need to move into other accommodations,
Yes.
other facilities.
Yep.
That number is going to get, I'm imagining, that number is going to get worse as the peak baby boom moves into that
Sure.
time of their lives. So what is our plan to take care of them and provide facilities for them?
Exactly. So I announced a number of new nursing homes when I was Minister of Social Development. They're coming online. Some are replacements, some are new. And that 461, that changes on a regular basis, and it's not always the same people. So sometimes concentrating on the time on the wait list as opposed to the number is the important. So if people are moving in and out on a regular basis into the care. But you have places like Shannock's that have a whole recruitment team. And you have, again, our department that helps the RHAs with recruiting. And I talked about Vitality's recruitment with a goal of hiring another 365 people in the medical field.
What if people can't afford to get into Shannock's?
Well, again, depending on your financial situation, the government pays a certain amount, and others, and then you're depending if it's a special care home or a special care home with extra services, or again the nursing homes. So that's a whole other discussion. Again, on if you can't afford, the government steps in. But the point being is, again, there's a lot of work going on in the recruitment and retention of the individuals, so that those beds that are available throughout the sector or throughout the province can be filled by people there. And again, trying to be sympathetic to the needs of those individuals as well. They won't be forced to move to Campbellton or Campobello. Great, there's beds in both those locations, but somebody in Moncton would rather be at Jordan or Spencer or some of the Shannock's buildings that are being built in that location.
I'll come to you in one sec. Go ahead.
Yeah, and one of the problems the hospital is I am, and they're overworked. We all know they're overworked. I'm not sure they're getting the same level of care. Those 461, the last number I've got, they don't have the same level of care in the hospitals that they would get in the nursing home. They have to be moved, they have to be turned, they have to be washed, all
Right.
those things. We've heard stories, not only one, of people got in the hospital, waited 30 days because they couldn't be moved elsewhere. After 30 days, they came in, they could walk, and after that, they weren't moved enough, so they couldn't walk. So there's that aspect as well that we're not taking into account, but it does happen. And it's all about fluidity. You get people in, you hope they get treated well, and then you give them a respectful place to live so they can, live that chapter of their life with dignity. Right now, every angle you look at it always comes down to staffing. And that's why the focus, I'm always going to bring the focus there, because there's the focus, there's what needs to be. And do they have the same codes, the nurses, to take care of seniors in hospitals as in long-term care facilities? Because I know in long-term care facilities they have hours of care every day they have to give to the patients. So I don't know if they have the same code. I know they probably.
What do you mean
not
by code? The same code?
The same rules, the
Hours
same
of care.
hours of
Okay,
care.
okay,
Like
okay.
in a long-term
Okay.
care, you have hours of care every
Okay.
day that you have to give to the patient if you have enough staff.
Okay, so are you suggesting, Mr. Gauvin, that there are beds available that would take some of these people from this list of 461 that you brought up? They could be moved into those spaces, but there aren't staff to care for them, so they're not being
Well,
moved?
it's one of the problems, because why are they
So
still?
beds are available, but they can't be moved into those beds because we don't have adequate staff? Is that the
Someplace
situation?
It's one of
And
the
again,
situations.
Yeah.
Yeah, it's a fluid situation, but I know, for instance, in Sussex, there were some beds that were available that didn't have the staff. Now, there's been a change of administration there, and they've hired, so those beds are now open. So the other thing that was done was a social worker was hired to work with the discharge planning team, and to again look at the various options, because those people, if they had enhanced home assistance, maybe they could go home. Maybe they could take some of the special care beds which are nursing home beds, but with extra clinical assistance. And that's what we've done too, is gone to some of the special care homes that can accommodate patients with a little extra mural or again, some of those clinical issues that they need to again, move the people through the continuum out into the places where you're right. When I was SD minister, I increased the hours of care in the nursing homes. And again, that was met with a positive response.
Megan Mitton, you wanted to jump in.
Often when we talk about ALC beds, so alternative level of care beds, it is easy to forget that we're talking about people who are being forced to live in the hospital because they don't have the supports available to them, whether that's a nursing home bed, whether that's a home care worker, personal support care worker, whatever that looks like, to not have to live in the hospital, even though they don't need to be there. These are people, and as was said, who may even lose some of their mobility if they're not able to get up and walk around. They're having to live there. And who knows, there are so many people who are being forced to live in hospitals, even though they don't need to be there. They could be in a unit that isn't appropriate for them at all. It doesn't mean necessarily that they're even in a unit that's with depending on, like, it's suitable for them, or necessarily treating what they've been dealing with. And so staffing is absolutely important. The other thing, though, is talking about housing. I don't think we can get away from talking about housing, whether that be for actual staff. There have been issues with, nurses, doctors, whoever, having trouble finding housing in order to be able to take a job. But seniors looking for different types of housing. I met with some folks in Bay Verde, a seniors group who has coffee, and one of the key things that they talked about was needing different type of housing. They have, there is a great program, Nursing Home Without Walls. It started as a research project out of UTM and across the province, and they help people to stay in their homes by offering support. But they are saying that there needs to be creative solutions around housing, so that there could be shared housing, maybe some support, but so that one person maybe not living in their home alone, or even some sort, and looking at rural areas, because we often ignore rural areas when it comes to things like housing and these supports, but it's really essential. If we want to talk about keeping people in their homes, maybe it's a different place. It's not a nursing home. It's something else in between. And so I think we really do need to talk about housing, because it's not always going to work with the resources that exist right now and the solutions that exist right now.
Mr. Fitch, is that one of the things that you're looking at?
Yeah, no, and you reminded me of the Healthy Seniors pilot projects that are going on throughout the province, and the Nursing Homes Without Walls is one of the more successful ones. But another one that is really interesting is a mobile X-ray unit, and that's run out of Loch Lomond in St. John, but it encompasses, is shared by 13 different level care, some special care homes, some nursing homes. And they've prevented, in the 6 months that it's been up and running, about 200 visits to the emergency room. A senior will have a fall or start complaining about a sore wrist or a sore leg or ankle or whatever. They can X-ray them right there in their bed or in the nursing home, as opposed to calling the ambulance, getting them up to the ER, and having to wait for a period of time. So what I'm going to tell you, this one, I want to see that expanded across the province, where there's more than just one of these units. But preventing the seniors going to the emergency room or having to wait for a hip X-ray to see if it's broken or not, that's again a very, very good use of resources, and it's one of those new ideas that's just come to fore.
And this all connects to some other things. Again, we can't look at healthcare without looking at what's happening in people's lives. So looking at, I'd say, poverty rates, if we don't have an approach around it's not just seniors, this is across the population, how are people living, are they living in food insecurity so they don't have enough to eat? That's happening with a fifth of the households in the province. And then if they don't have access to primary care or an urgent care center, maybe they don't need to go to the ER, but they need some care pretty quickly. And again, especially in rural areas, but it's happening in urban areas too, that they can't access that. But then transportation, public transportation, basically doesn't exist in a lot of the province, but it's a real barrier for people being able to access medical appointments. When I've spoken to people, and even when there were the healthcare consultations around the province, transportation was one of the key things that came up. And so we need to look at the whole system. And again, looking at what are the preventative interventions. If it's that someone needs public transportation to get to an appointment, and that's going to mean that down the road there was an earlier intervention and then they didn't need to be hospitalized. Like, it's all connected. And if we don't invest in this public infrastructure and these systems to support people, then we're dropping the ball.
Yeah, and we have also to, we haven't talked about enough about this in this panel because a lot of things to cover, but the mental health aspect.
I did want to go there, and
Yeah.
I got told a couple of minutes ago that we had 10 minutes left. But
Okay, but I'm going
Go ahead.
Thank you. The mental health aspect, like a few weeks ago, I think 2 weeks ago, there was a polling that 50% of people are fearful that they won't get the care they need if and when they need it. That's the mental health aspect, and more the percentage augmented 33% during the pandemic about mental health issues. So we need to join healthcare with mental health care as soon as we can, and we need to do a better job because more and more cases are related to mental
Let's
health.
make it free too.
Yeah.
Well, just,
Go ahead.
I'm going to plug eVisit NB because this is an opportunity. I don't know what my colleagues think about this, but it's free, it's Medicare.
I mean, speaking of the privatization aspect of it, but go
Yeah.
on.
Well, I'll tell you this, when you look at the other provinces and how they're reducing wait times, we've got to think outside the box on a number of things. And the cataract clinic up there, I don't know where you stand on that. 2 of your colleagues were up there, very, very supportive of that, because again, what it does, it reduces that wait time. And there was actually 2 nurses that came out of retirement to work for the good doctor.
Yeah, and we're not saying there's only problems.
No.
But our job is to try to fix the
Yeah.
problems that we have.
Well,
right?
let's just talk about eVisit for a second, and I know we're running short of time, but that is a platform where you, an individual, can go and talk to a doctor, a nurse practitioner, an RN. They've hired actually 40 NPs, nurse practitioners, who are available, and their turnaround time is about averaging 15 minutes to get an appointment and
Okay.
to talk to someone.
Impressive.
It
Let
is.
me just jump.
And last week, I believe the number was 3,500 people that they had an appointment.
Wow.
Just,
Okay.
if I can.
Well, no, hold on
You
one
can
sec,
get
because I
your
just want to say this.
prescription-
Yes.
Prescription renewed, you can get appointments, all kinds of things. Your pharmacist, they're expanding their scope of practice. So if it's a urinary tract infection, if it's your high blood pressure pills, and any other kind of pills that you might want, I was.
I've got to
Doing
jump
the
in here
pitch.
because here's what I want. Here's the thing that I'm really embarrassed that I didn't get a chance to deal with this, but I wanted to talk during this panel today about the people who are walking on our streets, who clearly are struggling with mental health issues, living in tents and bushes and sleeping in doorways.
It leads to addiction. Yeah.
Right.
Oh,
I mean, what is our plan in the 2 minutes I have left? What is your plan to deal with those people?
I know, my heart aches when I see someone who's in that situation and how they got there, what choices occurred or that were theirs or untheirs. But anyways, regardless of that, I know Minister Shepherd in the House this morning talked about the winter plan for out of coal, and I think she mentioned that it would be by the end of the week that she would be making announcements on how it's going to happen.
Okay, go
I
ahead.
know, and on mental health aspect, I'm thinking also of the workers. There's nothing more frustrating for the nurses. They are not staffed enough to take care of the patients, and they know they can't give the proper care to the patients because they're not staffed enough. They suffer as well, that aspect. So we have to think about that because this is a big part of it.
We need to stop having, let's figure something out for the winter approach, and then it just falls apart in the spring.
It can't just be seasonal.
It is more than just a winter approach when you look at some of the things going on.
But the thing is, there's not a housing first approach, or else people would be housed. There's an increase in people being unhoused. There needs to be a housing first approach, and there are other things that could be done. In addition to free mental health care, there could be more access to naloxone kits and test strips. The website needs to be updated, and then there needs to be efforts for a safe supply, and that needs to be worked on with the federal government. But there is a lot more that could be done, and it's not being done. And again, comes back to housing in this case. There needs to be an actual legitimate plan that's going to increase affordable housing in the province, and right now, nowhere near enough.
Boy, I could do a third. I could do a third panel on
Let's do another hour.
on
Just to
healthcare.
respond quickly, you know, you look at, and I know I've mentioned the Marcella Bruns project across Fredericton. I know that's just one, just an example
And
of
it's
some of the
great.
good work
And
that's
we-
being done,
we need
because you
more.
minimize the work that's being done time and time again, and
Do you
that
know what?
discourages some of the
Do you know what?
workers.
The-
You know, instead of praising people and
Okay.
saying, you're doing a great job, we know we need to do more,
I-
everybody knows we do more, so let's work together.
You know what?
Work
The people-
together, we've
Go
got the
ahead.
tools, the
The workers
technology.
who are doing that on the front lines, no criticism for them. I'm criticizing the government's 10-year plan to create 1,200 housing units, not even all of them new builds, when the housing, NB housing wait list is now over 8,000. It doesn't add up. It doesn't even make a dent. That's what's frustrating.
At the
Because
end of
what
the
it
day-
means is people are unhoused
Yeah.
and
All right.
in stressful
At the end of the day,
situations.
we need to find people, because it can, and you said baby boomers, the elastic is not gonna suffer much more.
Yeah. Well, stresses. I mean, you can't even catalog all of the stresses that the healthcare system is facing. Minister Fitch, thank you so much for making yourself available. I appreciate it. Your presence here is important.
Good to see you again, Terry.
Yes, thank you very much.
Again, I hope you enjoy retirement.
So far, so good. Mr. Gauvin, thank you very much for your time.
Great to
And
be
Ms.
here.
Mitton, thank you for your time. I
Thank you,
really
Terry.
enjoyed the discussion. That is our panel for today, and we'll be back in 2 weeks. And I'm toying with what we're going to go after. I'm almost convinced that we should do another one on healthcare, but there are some other big issues going on in the province right now too. Property assessments, MB Power, and I think that's probably where we're going to go next week, because that's a juicy one. So if you have suggestions, we have some suggestions already. Please send them in, and we'll put them on our list, and we will get to them. Thank you for watching this panel, and I'd like to thank Tara King-Stewart, who's doing all the electronic wizardry at the back, and I'd like to thank Jeff Dupre for his work in making this panel happen. Thanks very much for watching. We'll see you in 2 weeks.